Hi, I am Rasan Majalati Naval, a fourth year medical student of the Davao Medical School Foundation. Today, we are going to talk about Hordeolum and Chalazion. So, what is a Hordeolum and what is a Chalazion?
A hordeolum is a small, red, painful lump that grows from the base of your eyelash or under the eyelid. Most hordeola are caused by a bacterial infection. A sty is very painful, often appears at the eyelid's edge. It often swells, sometimes affecting the entire eyelid. A chalazion is a swollen bump on the eyelid. It happens when the eyelid's oil glands clogs up. A chalazion is not usually painful.
What are their differences?
Chalazia differ from hordeola in that they form as a result of gland obstruction and sterile inflammation rather than infection. Whereas a chalazion is characterized by a mass of granulation tissue and chronic inflammation, an internal or external hordeolum is primarily an acute pyogenic inflammation with polymorphonuclear leukocytes, and necrosis with pustule formation. In general, chalazion tend to be large, less painful, and have a less acute presentation than hordeola. However, one condition can result in the other. The acute inflammation of a hordeolum may eventually lead to a chronic painless chalazion, while a chalazion can also become acutely infected.
What are their pathophysiologies?
For hordeolum, there is usually underlying meibomitis with thickening and stasis of gland secretions with resultant inspission of the Zeiss or meibomian gland orifices. Stasis of the secretions leads to secondary infection, usually by Staphylococcus aureus. Histologically, hordeola represent focal collections of polymorphonuclear leukocytes and necrotic debris. Essentially, a hordeolum represents an acute focal infectious process. Chalazion form when lipid breakdown products, possibly from bacterial enzymes or retained sebaceous secretions, leak into surrounding tissue and incite a granulomatous inflammatory response. An alternate name for chalazion is conjunctival granuloma. Since meibomian glands are embedded in the tarsal plate of the eyelids, edema due to blockage of these glands is usually contained on the conjunctival portion of the lid. On occasion, the chalazion may enlarge and break through the tarsal plate to the external portion of the lid. Chalazia due to blockage of Zeiss glands are usually located along the lid margin. Chalazia form when underlying meibomitis results in stasis of gland secretions, and the contents of the glands, or sebum, are released into the tarsus and adjacent tissues to incite a non-infectious inflammatory reaction. Histologically, chalazion appear as a granulomatous reaction, surrounding clear spaces that were once occupied by sebum or lipid before they were dissolved by the solvents used for tissue processing, hence the term lipogranuloma.
What are their causes?
Hordeola are associated with Staphylococcus aureus infection. Patients with chronic blepharitis, meibomian gland dysfunction, and ocular rosacea are at greater risk of developing hordeola than the general population. There are published case reports where multiple recurrent hordeola have been associated with selective immunoglobulin M deficiency. Chalazion could be caused by acnea rosacea, chronic blepharitis, seborrhea, tuberculosis, and rarely, they may be an indication of an infection or skin cancer.
How do you manage them?
Hordeola are usually self-limited, spontaneously improving in 1 to 2 weeks. Medical therapy for hordeola includes eyelid hygiene, warm compresses of the lesions for 10 minutes 4 times a day, and topical antibiotic ointment in the inferior fornix if the lesion is draining or if there is an accompanying blepharoconjunctivitis. If an external hordeolum is centered around a lash follicle, the lash can be pulled to enhance drainage. Systemic antibiotics may be indicated if the hordeola is complicated by preseptal cellulitis. Oral doxycycline may also be added if there is a history of multiple or recurrent lesions or if there is significant and chronic meibomitis. Internal hordeola may occasionally evolve into chalazia, which may require topical steroids, intralesional steroids, or surgical incision and curettage. An ophthalmologist should perform the incision and drainage under local anesthesia. The specimen should be sent to pathology to rule out more serious diseases, including carcinoma. Most chalazions require minimal medical treatment and clear up on their own in a few weeks to a month. Apply warm compresses to the eyelid for 10 to 15 minutes, 4 to 6 times a day for several days. The warm compresses may help soften the hardened oil that is blocking the ducts and allow drainage and healing. Create a warm compress by dipping a clean, soft cloth in warm water and then wringing it out. Re-moisten the cloth frequently to keep it wet and warm. Gently massage the external eyelids several minutes each day to help promote drainage. Once the chalazion drains on its own, keep the area clean and keep hands away from the eyes. If the chalazion does not drain and heal within a month, you may visit an ophthalmologist. Again, do not attempt to squeeze or pop the chalazion, as it may inadvertently cause more damage. If the chalazion does not go away after several weeks, it may require medical treatment, which may include an incision to drain or an injection of steroids to reduce the inflammation and swelling.
These are my references. And now you know the difference between a hordeolum and a chalazion. Thank you!